I'm going to talk to you all about the psychosocial effects of parenting a child with a GU diagnosis. And I thought I would kind of start pretty broad about pediatric psychology and parent-child adjustment, and then we'll kind of narrow it down to specifics about parents of children with bladder exstrophy. So overall, parents, and for my talk, I will use the word parents, but caregivers is probably more appropriate. So this can be grandparents or friends or anybody who plays kind of as a primary role in helping to take care of your child. So any parents or caregivers of children with a chronic medical condition are at increased risk for things like depression, anxiety, like Dr. Kropp mentioned, stress, which could be related to the child's illness, but it could also be related to having a more difficult child or your own distress as a parent. I'm sorry, your own distress as an adult. Post-traumatic stress, and we're going to talk a little bit about this in a couple of slides. Uncertainty, and this is really important because it's such a broad idea, but it's such a robust predictor of depression and anxiety, especially in parents. And so this is the notion of your child gets a diagnosis, one of which you might have never heard, and now you have to kind of figure out, what does this mean surgically, what does this mean medically, do you understand the prognosis? Do you actually understand the diagnosis? Do you have communication with your medical team? And what we know is that uncertainty never goes away. It just waxes and wanes throughout an illness. And so it's really important that we're able, and we'll talk about this at the end too, but to give our parents those skills that are necessary to be able to manage that uncertainty. Parental overprotection, and this goes back to something that Barbara had mentioned in her talk, but making sure that we are parenting in developmentally appropriate ways and not being overprotective. So if your child is at an age and the developmental level at which he or she is able to self-cath, we need to encourage the child to do that. And then perceived vulnerability, and this is just thinking of your child as being vulnerable, being sicker than other kids. And perceived vulnerability are thoughts and beliefs, whereas parental overprotection are behaviors, but they go hand in hand. And then families are also at risk for decreased social support. Again, something that's been touched on today, and a lot of that, and I love Barbara's, your quote, below the waist, under the radar, thank you. I kept thinking. And so I think it's really important when we talk about GU conditions, because there is a lot of secrecy and privacy surrounding these diagnoses, which may affect how parents are able to access social support. And then problem-focused coping skills. Often when we're in the midst of having to make really difficult decisions, a lot of emotion plays a role, and sometimes people make hasty decisions because of things like anxiety. So this is the Pediatric Psychosocial Preventative Health Model. It's based on a public health framework, and it's used to conceptualize families with varying levels of psychosocial risk, and then to identify interventions that are matched with that risk. And so the interesting thing about this is this was started by Ann Kazak when she was at CHOP in pediatric cancer. And what she found is just this triangle. So at the base of the triangle are families that fall into the universal category. So they are understandably concerned or distressed about the child's health problems, but they're generally resilient and able to cope pretty well. The middle section are considered targeted families, and these are families that may have pre-existing concerns or difficulties that may contribute to continuing problems after the child's diagnosis. And at the tip of the pyramid are clinical families, and these are families that are defined as having one or more pre-existing chronic and complex problems and resulting in the greatest need for prompt and often intensive treatment from a psychosocial perspective. And so what we see across illness groups, shockingly, is that all parents, there are approximately 15 to 20% of the samples that are reporting clinically significant levels of depression, anxiety, uncertainty, whatever we look at. So we know that the majority of our parents are coping really well, but it's something that's important for us as clinicians is to make sure that we're screening parents and monitoring as we go along, because it is possible to change levels. And especially if we have a family that's kind of going up the pyramid, we want to make sure that we catch them in time. Really briefly, pediatric medical traumatic stress, I'll read the definition, a set of psychological and physiological responses of children and their families to pain, injury, serious illness, medical procedures, and invasive or frightening treatment experiences. Some of these symptoms can include re-experiencing the events. So things like that diagnosis talk, the first time you heard the words bladder exstrophy, avoidance or reminders of the trauma, so not wanting to talk about it, whether it's with your partner or with your medical team, and hyperarousal, just being hypervigilant and worried. And pediatric medical traumatic stress is kind of broken into 3 categories based on time. Can you see this? So as time increases, this is the x-axis, and then traumatic stress. And so this first time point is peri-trauma. And so this is the time around diagnosis and those immediate kind of first surgical procedures or anything that needs to be done. And then we get into the acute medical care. And so this might be where some of our kids are having their closures. And then we get into the ongoing care, the third section there. And that's long-term. That's whether we have problems with continence or eventually sexual dysfunction or needing more surgeries. And so again, at the bottom, it just shows that we really do need to be screening our parents. And as you can see, that top line kind of divides. So we have a group of parents that seem that they're doing okay, and then all of a sudden, some of them will escalate, some of them will continue having chronic stress, and then some of them will drop off. And then the resilient ones are low all the way across. So I have a little bit of background for you, and this is data that our group has collected on parents of children with born with atypical genitalia. We know that caregivers of undermasculinized males were at increased risk for depression even 10, 15 years down the road. Male and female caregivers are differentially affected by decisions about genitoplasty. So for moms, the decision about whether or not for the child to have surgery, is related to elevated levels of parenting stress. And for dads, it seems that the biggest question is if the child's gonna have genital surgery, should it happen before or after the age of 1? Parenting stress is related to anxiety and depression, and perceived vulnerability is related to anxiety. So again, those constructs that I told you about on that first slide, they really play off of each other. Female caregivers of boys perceive their child as significantly more vulnerable than female caregivers of girls. Again, this goes kind of back up with that first point. And again, the majority of parents cope well, but 25% report having significant distress. So this is an ongoing study right now. We are in, I believe it's year 4. We just started, sorry, we're in year 4 now, of an ongoing project. It's based on an R01 that Dr. Amy Wisniewski, who's here at OU in neurology, and Dr. Mullins, who's up at OSU as a psychologist, have. It's an 11 hospital consortium. You can see all the locations. We are collecting longitudinal data looking at outcomes of genitoplasty. And so we are collecting patients that are under 2 years of age. We're looking at baseline data in terms of we're looking at surgical outcomes, but we're going to collect baseline psychological data on the parents, and then we collect them again 6 months post-operatively, and we are going to continue to collect them at 1-year intervals. So I'm going to show you kind of the first wave of parents that we have. So again, 2 different studies, one looking at surgical outcomes. That 6-month paper is under review right now at Journal of Pediatrics, and then my paper that's looking at the 6-month psych functioning is also under review at Journal of Pediatrics. So the parents that we have that have the 6-month follow-up, there are 45 of them. And I'm going to just point out a few things because I think it's something that we need to keep in mind. So we have 25 moms and 20 dads, and these are actually all biological parents. Their average age is about 33 years old. The majority of them are Caucasian. The vast majority of them are married, and if they're not married, they're living with their child's biological parent. More than half of them have at least a bachelor's degree, and more than half of them report an income of more than $90,000. So when we look at these statistics, we need to think that this is probably a biased sample, and it's not generalizable to maybe all of the parents out there of children born with atypical genitalia. But in theory, these should be the parents that are quote, functioning the best from a demographic standpoint. And so if parents in this group are reporting clinically significant distress, then we would think that it's even more of a deal, for other parents. So here are a few graphs, and I will not bore you with statistical significance, even though I love it. So the purple, it's not working, are the baseline measures. The middle are the 6-month follow-ups. And then on the end, I added some data that we have from parents of kids with pediatric cancer. Because I think this is something actually that Dr. Kraft had talked about, that it really kind of gives you an anchor to look at, because I think most people hear pediatric cancer and you kind of lose your breath for a minute. And so as you can see, our parents, in terms of depression, there was a slight decrease, but they weren't significantly different than parents of kids newly diagnosed with cancer. Similarly, for anxiety, you see that little dip, but again, not significantly different from our cancer parents. Level of illness uncertainty is actually kind of the most concerning slide to us, because if you'll notice, it actually increases slightly, not statistically significant, but still concerning. We would actually have expected that 6 months after surgery, all of the psychological distress would have gone down, right? Because we were thinking that these parents are stressed about whether or not the child should have surgery and going through surgery. And then if you look at level of post-traumatic stress symptoms, this is exciting to see, but there's a significant drop between our baseline and 6-month follow-up. And again, not significantly different from parents of kids with cancer. And then this is looking at quality of life. So in the previous slides, lower levels are better. In these slides, higher levels are better. And we don't really see any significant changes in quality of life for our parents, which again is concerning. But what's really interesting is when we separate our sample into parents of boys and parents of girls, because historically we have reported that parents of boys are at increased risk, and those blue lines are parents of boys and the purple lines are parents of girls. And as you can see, that in terms of depression and anxiety, you can see that they're higher, even though they do improve or slightly improve. But what's really concerning is this illness uncertainty, and this is what I was talking about just a couple slides ago, is that while parents of girls seem to stay the same, parents of boys are the ones that are reporting more illness uncertainty. So again, this is consistent with what we have found in our other studies, but now we're looking at it from a prospective experience. And a couple hypotheses about why this might happen is that many of our boys have to have 2-stage procedures. 50% of the kids, of the male children in the sample, will not have a clinical diagnosis, which can also lead to some stress for parents. And then again, we have levels of post-traumatic stress. They came down. Levels of quality of life. And so again, remember these two, it's switched, so parents of boys are lower on both of them as well. Oops. Okay, so some challenges of bladder exstrophy. There's closure of the bladder, urethra, and abdominal wall, preservation of kidney function, establishing urinary continence, creation of cosmetically acceptable external genitalia, and functional internal genitalia. And as you all know, this can come with a lot of surgeries, a lot of doctor's appointments, possible complications. And then we look at the long-term sequelae of bladder exstrophy, things like having urinary incontinence, the need for CIC, recurrent UTIs, and sexual dysfunction. And so now we're going to get to, sorry, I'm talking really quickly. We're going to get to the parents of kids with bladder exstrophy. And I was shocked. So I looked at, this was not an exhaustive lit search by any means, but I went into PubMed and just kind of put in parent, bladder exstrophy, parenting, bladder exstrophy. I threw cloacal exstrophy in there. And I came up with one article that actually had data from parents on their own functioning. So parents were involved in other studies, but they were always reporting on how their child was doing and not necessarily on how they were doing. There were some qualitative pieces. So the qualitative section, parents were reporting having to leave work early or waking up during the night to help empty the child's bladder. having to accompany the child on school field trips. And the quote that I saw was immense feelings of isolation and psychosocial support due to the rarity of bladder exstrophy. That really resonated with me because that's a pretty strong word. And then in a study looking at mental health of adolescents with bladder exstrophy, they found that parental warmth was the best predictor of the child's mental health. And again, like Dr. Kropp was saying, we need our parents to be coping well in order for our children to be coping well. That the best predictor of child outcomes are parental adjustment outcomes. And then this was taken right out of that one article that exists. And so if you look, you'll see the items, and this is on a parenting stress inventory. You can kind of skip that middle column. The numbers aren't so important. But if you look on this frequency column, it's the number of parents, I'm sorry, the percentage of parents who rated this item as occurring either often or very often. So things like worrying about the long-term impact of the illness, watching the child during medical visits or procedures, feeling helpless over my child's condition, having little time to take care of my own needs. And based on the numbers, the assumption is that some of you in this room have definitely felt some of the stress. So now what do we do with it? So our conclusions that our parents of children with atypical genitalia are similar to parents of other medical conditions, parents of children with other medical conditions. Approximately 20% of them are having clinically significant problems, and parents of boys are more at risk than parents of girls. Sorry, those slides should have been switched. But anyway, so if we go back to that first model that I showed you, that PPPHM, and we think of it from now an intervention standpoint, we can look at types of interventions. Some of these would be kind of more lower level, but could certainly be used by all parents, regardless of what level you fall at, but to increase your social support. So you can do that using online support groups, attending conferences like this, close friendships that you have that you can talk with your friends about your child's diagnosis and that you feel that you're able to open up to them. Some people find a lot of support in religious groups or church groups. As I typed this, I kind of laughed to myself, but engage in self-care activities. So as a full-time working mom of 2, I know this is not easy, but finding hobbies for yourselves, taking breaks, just realizing that you can't be the parent that your child needs if you can't take care of yourself first. And then activities of daily living. So making sure that you're doing things, taking care of yourself. I know it sounds really crazy, but getting up in the morning and showering and washing your hair and changing your clothes, even if you put clean sweats on or clean pajamas on, but you're still making that effort to get up. Because with all of the stress and all of these emotions that you're dealing with, again, throughout your child's diagnosis or your own diagnosis, you're at risk for wanting to just curl up in a ball on the couch. And so getting up and showering at least gets you off the couch for a few minutes. Other ways that y'all can help to deal with some of your distress is increase your knowledge. So read about the diagnoses, read about the treatments, but do not just Google blindly and believe everything that anybody has ever written on the internet. So there are places, the ABC website, there are places that you can go and find good, legitimate, scientific sources that you could read. Talking to your medical providers, ask them questions, reach out to other parents. So again, parents that you might meet here, or that you have online relationships with, but reach out to them because they can really understand what you're going through. And parents of children with other chronic medical conditions, there is an overlap in what they've been through in terms of what you've been through. But again, Barbara's comment about below the waist, under the radar, there are differences. More communication with the medical team. So if you can identify 1 or 2 people somewhere on the medical team with whom you click, whether it's a psychologist, a social worker, a nurse practitioner, one of the surgeons, one of the other medical providers, and they can be the liaison between you and the medical team. And oftentimes these multidisciplinary clinics have someone who's specifically Their job is the patient liaison, and so hopefully they can be your voice, but it's okay if that's not the person you click with. You need to find who you feel most comfortable with. And then ask questions. Barbara had said it too, there's no stupid questions in any of this. You're not expected to walk in on day one and understand what's going to happen in the operating room. And you hear our surgeons talk about how many years of practice and experience it takes for them to feel like they truly understand and they can do this. And so as a parent, you're certainly not expected to know all of this. If you're starting to get up into the middle and top of that triangle, you can seek out professional support. So individual and or family therapy, and I should really put in marital therapy as well. Again, what was said earlier, talking about taking time for yourselves as a couple. Trauma-focused cognitive behavioral therapy is kind of this new TFCBT, because we like talking in acronyms, is actually kind of based in Oklahoma, and they train therapists all over the country. And so it's a short-term problem-focused treatment, but for people who have any histories of trauma. And trauma can be anything from abuse to a difficult diagnosis to a child's difficult prolonged hospitalization. And so if you feel like you might be in that area, you can actually just Google TFCBT and you can look for therapists. And then emotion-focused versus problem-focused coping, and this is something that I had touched on briefly in the beginning, but a therapist can really help you to identify how to take your emotions out of your decision-making process, making sure that you're not making decisions based on your emotions, but based on the evidence that you're provided. And something that I'm super excited about is we have a grant under review right now at the NIH, and our plan is to take a 6-module intervention that's targeted at teaching parents how to manage their uncertainty. It's already been shown to be effective in parents of children newly diagnosed with diabetes and in parents of children newly diagnosed with cancer. And so now we're bringing it to our parents of children born with atypical genitalia. But what we're doing is we are making it internet delivered. So in my mind, it could go worldwide. And so we are waiting to hear about whether or not we're going to be funded, but this is kind of the next step. And when we're talking about rare conditions, we have to figure out how do we get these interventions out to families, because it's not realistic to think that they're going to travel to our clinic every week to meet with me for 45 minutes when they live 6 hours away. And so we have to try to figure out how do we get that support out there. And that is it.